All right, ladies and gents. So, for those that don't know, Sean's currently the baseball athletic trainer at UGA. He has been there going into his sixth season since 2014, and before that, he spent 6 seasons at Troy University, where his experience comes from. Sorry, I lost my train of thought there. He served as an adjunct faculty member at Troy as well, teaching classes and athletic training in the education department. He also spent time in an outreach athletic trainer and champion sports medicine, covering Pike Liberal Arts School. He has experience including serving in PBATS, an intern for the Atlanta Braves in 2008, and took part in a pair of summer internships with the Augusta Green Jackets, their single A affiliate for the San Francisco Giants. Over his career, he's added several certifications, including Graston, CES, and PES, and he currently resides in the wonderful state of Georgia with his wife and 2 children. And take it away.
Awesome. I appreciate the opportunity to speak and give you guys kind of my experience with the internal brace procedure by Dr. Joe.
Your internal bracing augmentation.
We there? Sorry. Sorry, I got distracted there for just a second. So moving forward, I couldn't do this presentation without Dr. Jeff Dugas. He's the kind of creator of the internal brace. And then also Leslie Parrish was a physical therapist, or is a physical therapist at Troy University currently. Wonderful practitioner and a big help to me during this process. So what is the fiber wire that Dr. Dugas uses? What is it kind of constructed of? These are just some photos from Arthrex's website that show the collagen-coated fiber wire. It's bovine collagen that comes pre-loaded and ready for the surgeon to be able to use. So things that I would highlight to you are these kind of microfilament that gives it the tensile strength that I'll show here in just a second. This is another photo. It's a rotator cuff repair in the top right, but an enhanced zoom to give you an idea of those microfilaments that we're talking about that add to that tensile strength. This is a document that was put out again by Arthrex, so maybe a little skewed, but I would call your attention right up here and just take a look at the Newton meters that the fiber wire was demonstrated. So you can really appreciate pretty quickly how strong this stuff is. And so that's what led Leslie and I to have some confidence going into the rehab process with our first student athlete that we weren't going to pull this loose. We weren't going to damage the surgery in any way. So we just were able to have some confidence knowing that this stuff's really strong. So I want to start with patient number 4. I've got the best photos of that patient, and so that's why I started with him. A 17-year-old two-way player, right hand dominant. At that time, had a partial tear of his proximal UCL and chose to go through the augmentation with fiber tape in June of 14. He also had an ulnar nerve transposition. I know in the MLB talk, Dr. Dugas discussed that, whether he transposes it or not. So in this case, patient number 4 did have the transposition. Interestingly enough, this gentleman also had a mesenchymal stem cell injection at the same time. The next 6 photos that you'll see are patient number 4 in his second PT visit. So this is week 2 post-op, but his second physical therapy visit. So these are his range of motion photos of that second PT visit. That's the lateral side of the joint. Now we'll move to the medial side of the joint. So to me, these are just absolutely fascinating that this amount of range of motion in your second PT visit. You can see there his steri strips haven't even been removed yet. So we took our knowledge that Dr. Dugas taught us about the strength of this Arthrex fiber wire, and Leslie and I put our heads together and tried to help create or use the UCL protocol that already existed and adapt it. So this is week 1 of that protocol. Tells you that you still have that elbow range of motion brace that we're maybe used to, but you've got more range of motion to work with early on. We're going to talk about later why I think that may have a little bit to do with why this can go a little bit more rapidly. So here's the acute phase, week 2 through 4. This is the Donjoy elbow brace that we used while I was there at Troy, and I still use here at Georgia. Gives you really easy flexibility to be able to change your range of motion parameters. This is still patient 4. This is at the 4-week mark. You can see in the photo that his incision is healed very nicely. He's back to full range of motion of his elbow. So Dr. Dugas and I had a very nice conversation to try to answer this question at the top. Why is the repair rehab faster? And I think I brought up to him that I thought that the rehab was faster because you get that range of motion that I described earlier. You get that range of motion back, in my opinion, faster. And he sort of changed my mind to that. And he said, think about the ligamentization process that has to take place with a traditional UCL. We're not waiting on that process to biologically happen. That biological process takes time. You really can't speed that up that we know of. There's some argument or there's some question, does that collagen that the fiber wire is dipped in, does that help us to speed up healing of the native ligament? We don't know that. That'd be a difficult study to do, to go back and do these with a control group. So in his eyes, the 6 to 8 weeks of not having to have that ligament switch over is what speeds this process up. For me as an athletic trainer and for Leslie as the PT, it was really good for us to see that quicker elbow range of motion that we were used to from compared to a traditional UCL. It helped us to not have those sticking points that you commonly get to with brace stiffness or post-surgical stiffness. We didn't seem to have that in the cases that I've treated. It decreases the amount of pain meds that are needed. Usually Tommy John's doesn't require a whole lot of pain meds. Their pain's managed pretty well, but in my hands, in my experience with Dr. Dugas, we didn't really need much pain meds at all. And then they're back to activities of daily living. They feel like a normal human being more quickly. They're able to do things with their dominant arm that really helps them to normalize life pretty quickly. The internal brace, that Arthrex fiber wire really does provide you some valgus stability early. You have to be smart. You have to allow that bone tunnel to heal, but it does give you a secondary backup, if you will, to make sure that you're not causing harm during the early stages of the rehab. You're still smart. You're still not doing valgus exercises very early, but that internal brace does give you some stability. So this is patient number 1. We'll kind of call him our Tommy Johns. Dr. Dugas showed this video and showed this patient in the MLB talk. So I'll just briefly go over. He did have a partial tear of his proximal UCL. He's left-handed. He underwent the procedure in August with the sole goal of trying to get back for his high school senior season. So this was the exact patient that Dr. Dugas was looking for. The only previous surgical history he had was an ulnar nerve transposition, so that part was already done. So for him, he underwent the surgery, and then successfully we began the throwing protocol at 11 weeks, and that's the video that Dr. Dugas shows where he almost choked me for allowing the kid to get out there and throw that hard. But I'm still alive to tell about it, so we're okay. First competitive pitch was thrown in the game at 5 months post-op. Had a nice season, 4-2 record, 3.26 ERA. You notice his velocity is 76 to 78 miles an hour, not a very hard thrower, left-handed, but was 2 miles an hour more than his pre-surgery numbers. He went on and played summer ball. I have a video of him playing in summer ball in just a minute. And then did end up competing in 2 junior college baseball seasons and currently works as a firefighter. So this is a video just after his 11-week checkup with Dr. Dugas in the clinic. And this is he and I going straight out of the clinic onto the field to throw. So maybe a little more aggressive than I should have let him get away with, but he was ready and itching to get back out there. Give you a couple more views. My fault. Oh, I apologize. Pushed the wrong button. All right. So interestingly enough, the player that's on the mound is our left-handed pitcher. After he got back, this is a summer ball outing, and consequently enough, the hitter is UCL procedure by Dr. Dugas number 5. So you got UCL number 5 versus number 1, and we'll see who gets the better of the two surgeries here. So the elbow works, but you can still give up a triple. So we're going to have a kind of question and answer and discussion session sort of at the end, but Jason will take it from here. I appreciate the opportunity to talk. I want to open this to dialogue and find out kind of your thoughts about it, questions about it, and be glad to give any more information that I can.
So I'll preface this by saying that this is more Sean's wheelhouse than it is mine. I've only participated in one of these rehabs, but one of the requests that's popping up over the somebody unmuted. That's been hopping over the surveys is the idea of more research-based reviews in here. And so I've just compiled some of those things and tried to pull on a discussion at the end. Somebody definitely needs to be unmuted.
Hey, Sean, I got a question.
Sure, go ahead.
Yeah, Brandon with Florida State. What made you guys determine to use internal bracing over, say, stem cell or PRP?
So initially, it was Dr. Dugas looking for that ideal patient. He had a pretty good understanding of the surgery and what the Arthrex fiber wire could do. He just needed the first person that was for lack of a better term, a guinea pig a little bit. He was pretty confident in his surgical skills and what he could do. He just needed that person to be able to take the leap. So he was looking for a young baseball player that was looking to get back for a senior season. And this young gentleman happened to trust Dr. Dugas enough to be able to do it. And they went into the first surgery knowing that, hey, if this doesn't work or if this fails you in any way, then we'll go back and do the normal UCL surgery.
So obviously we can definitely fire questions away as you guys want to, but hopefully some of this will answer a few of those questions. So this is just some information that kind of sums up Dr. Dugas's presentation during the MLB virtual webinar a couple weeks ago. So obviously there's a heavy history of repair within the literature with poor results dating all the way back to the 1990s or early 1990s. 2 studies by Savoie. Hopefully I got that right this time. One with good results in 2008, and we'll kind of go over that study. But some of his big take-home points were the fact that age has a huge factor due to deficiency in tissue or arthritic bony changes. Arthrex, the company that's made the actual fiber wire, estimates approximately 4,000 of these have been done nationally. Mostly, and up to this point, obviously in date, mostly done in high school or college participants, which is good news for our guys as far as this being a viable option. Most, if not all, surgeons performing it are typically doing an ulnar nerve transposition because of scarring, which I think is a big piece to put in there. And one part that I found interesting that kind of corroborates the research, or the limited research that there is on this, which, like a lot of things, this practice predates the research, and that kind of has to happen in some degree to kind of figure out new ways of doing things. But KJOC scores are no different, and we'll get into a little bit of that later, in regards to a proximal versus a distal tear. Also, no difference between partial or complete ruptures in regards to the results for these guys getting this done, which is kind of interesting. He cited 10 Pro Ball players that have had it done up to this point, a host of NCAA, one of which he had to mention pitched in the College World Series for TCU. Way to show some bias. And he had used to perform this for revisions on original Tommy John patients, which I thought was interesting. The first MLB pitcher with a revision is actually slated to go back in this coming season, if that's what you want to call what we're about to have. The Savoie study. So this is primary repair in the UCL. This is the 2008 study. They had 60 patients. Kind of interesting, 2 separate procedures being done, and they utilized an Andrews and Carson elbow score to kind of figure things out as far as whether it was good results or not. So definitely an increase in results, as we can see over here, from a 132 to an 88. And this is a questionnaire score similar to the KJOC score. 58 of those 60 returned to sport within 6 months of surgery at the same level or higher. They had 4 failures, 2 early stage, 2 late stage, 5 and 6 years of unrestricted play, respectively, before those 2 late stage failures occurred. And then 3 complications due to ulnar nerve issues, but they resolved spontaneously. This is Dugas's study that he referenced inside of the MLB talk, and just some key points here. 111 eligible kids, 102 that decided they wanted to go back to a previous level of competition. And they compiled all that data. First surgery in 2013, which obviously kind of dates to Sean's presentation here. Return to play mean time of 6.7 months. I think one thing to make sure that everybody's aware of, for those that haven't dealt with anybody in this, is that all patients typically are instructed pre-surgery that they have no clue what's coming out on the other end until the doctor gets in there and cuts. So obviously there's some heavy waiver and hope there that things go in the direction that they want, and a lot of psychological considerations on the back end. Initially, which I thought was interesting, their inclusion criteria didn't really matter proximal or distal, as we spoke to before, but they scrutinized a lot over evidence for tissue degradation and just the presence of arthritis or how healthy that tissue is. As they went along, they kind of state in the study that they laxed on these criteria and allowed less scrutiny over this, which I think is interesting, but they don't necessarily state exactly how. And Sean and I talked a little bit, and obviously he's got a relationship with Dr. Dugas, and kind of just talked about the fact that, initially we had to make sure that they had to make sure that they filled in certain criteria and found the best patients to create an outcome that they were looking for. And then they got confident enough to the point where they realized that it didn't necessarily matter as much. Another interesting study that I think kind of falls along with this, Felsig in 2019 did a study regarding pitching mechanics shortly after the UCL repair. Obviously kind of a small sample size and definitely a small window of 9.8 plus or minus months compared to 33 other uninjured pitchers. Again, mostly players that are in our wheelhouse, 14 college, 19 high school in each group. And they measured passive range of motion, elbow, shoulder, and biomechanics of 10 fastballs using all of the fancy wizardry that they have down there at ASMI. They noticed very little difference, if no difference, from range of motion and fastball velocity or joint kinetics while pitching. They did notice that the UCL group actually had less elbow extension velocity, and less shoulder internal rotation velocity. Now, there's plenty of people in this room that probably know a hell of a lot more than I do regarding biomechanics and things of this nature, so hopefully this will be a fun topic when we get towards the discussion at the end. Another interesting study that kind of goes along the same lines is a Mayberry study in the American Journal of Sports Medicine, talking about jump mechanics or jump ability and how it relates to elbow injuries. So this study particularly used one organization, 500 plus pro ball pitchers, and a whole lot of acronyms for different jump styles and metrics later. And they found 3 key indicators: low rates of force development during an eccentric phase of the jump, high impulse momentum coupled with low force production during the concentric phase of the jump, and low impulse momentum coupled with high force production during the concentric phase of the jump. So to be noted here, all of these were done with counter movement jumps, but they found no significance for shoulder injury, just elbow injury, right? So it's kind of weird to me that our jump mechanics relate more to elbow than they do to shoulder, but you never really know, I suppose. And Sean's got a few other interesting things that they utilize down at UGA that kind of ties into this as well. Last one, I think. Yep, last study here to throw in here is one Sean actually sent me today that has a Wilk study regarding the actual rehab process that they've outlined. After looking at this, it definitely seems like, similar to the interval throwing program, right? Like this is something that anyone who's never dealt with an elbow or an overhead athlete before can follow and not screw it up. And they've utilized 350 cases, 79 with at least 1 year follow-up. It basically just outlines the 5 phases that they utilize in regards to return to athletic activity. And it's pretty interesting stuff. They list the brace being locked at 90 for 7 days in here. I've definitely seen other protocols that don't require that to a degree. Obviously, we're leaving it on for all rehab exercises or all stress exercises to make sure that we're just saving the joint and what have you. But some interesting stuff in here. And obviously, these slides will be sent to you guys after the fact so people can review if they want to. So at this point, we're going to kind of open up for conversation / moving things along in regards to just talking about the rehab process, right? So here's some major differences in my opinion, and then obviously some caveats that kind of follow the same lines. As Sean said, there's definitely a decreased period of worrying about range of motion in UCLR versus internal brace versus UCLR. Throwing and hitting is initiated between 8 and 12 weeks, and some even sooner, pending the doc and the protocol that you're utilizing. Whereas, we're in the long haul over here. The reconstruction, 4.7 months is what Stan actually alluded to in his research in one of our first roundtables in regards to when they're going to start throwing. The more I talk with people, the more I think that it needs to be pushed back to 5 or 6, just because of the amount of complications and arm pain that I've seen with patients when they do start earlier. And then obviously just high considerations for the kinetic chain and a holistic approach, and making sure, I don't think there's any kid out there that does this unless they're really young, where it's just overload or workload management. I think a lot of it has to do with a coupling of a handful of different things. Definitely put that in the wrong spot. So that's fun. So one of the things that we wanted to chat about and try and get discussion going about was, what we're returning for and how we're returning for. And this kind of came up in my thought process over the course of the last few weeks because of some of the MLB stuff, and just how are we actually doing batteries of testing to return people for upper extremity injuries. And there is a lot of evidence out there, but there's also a lot of stuff that people aren't using. And I think the bigger one for debate, and Sean and I are both interested if anybody wants to chime in on this, is this athletic shoulder test. I've heard that the Astros utilize this, but I'm all ears for anybody that utilizes force plate studies or anything at their institution. And we'll open this part to fire away.
Hey, Jason, it's Adrian over here. We use force plates over here at Rice. We actually just got them this past school year, the beginning of the fall. So we started using them here. The strength coach I work with, he's doing all of that with them, testing and retesting. You can get some really good feedback if you actually apply the information that you get from it. I know some places will just get them and they're like, all right, what do we do with this information? But my strength coach is the one that does all that. I can get a lot of that data from him and then share it. But you'd mentioned on the throwing, I actually just had a guy last Thursday go through this internal bracing procedure. So I'm getting ready to go through it again. Fortunately, unfortunately, this is the third internal bracing I've come across since I've been here at Rice. 2 of them got it, one before I got here, another one before he got here, And then this is my actual first one that happened while I was here. Ironically, the one that just happened was a position player, and he blew out on a single throw. I'll actually be going through this starting. He's got his post-op Friday where he gets his cast off. I can give a lot of feedback to whoever wants it as we go along, because it's going to be real-time data as they go. But the one thing that I used on my Tommy Johns, as far as, or even this, as far as throwing, was the Motus sleeve. I'm not big on data to begin with, so like all the data analytics and all that it gives out, I'm not big on it. But what I used was in the app itself, it shows you dips and peaks of how much they throw every single day. And showing these guys that, hey, all of a sudden yesterday you were at 120 throws on your throwing program, and then you dipped down to 15, 20 today, and then you went back up to 80. For me, I use that to show them, hey, here you need to get these two peaks closer together and taper to where you are as far as your throwing program goes, and your bullpens for the week or your outing. But I guess that was just what I've been using so far.
So you said your strength coach compiles all the force plate data. Do you utilize that for anything, Adrian, or no?
Yeah. Are you talking like me, or just like us in general?
You specifically, like, do you use that for anything like return to play criteria, or figuring out if anything needs downtime or anything like that?
Yeah. So I'll these guys. What we like to do is with these guys to get an injury, we'll test them on the force plates when they have the injury, and then if we know they're having surgery, we'll test them again when they start coming back, and then compare their numbers in the weight room. Once they get close to returning back to play, we'll retest them. The other one is it's not really related to this, but we also will bod pod them just to see how their body composition does, and then kind of look at everything as a whole approach, and then say, all right, hey, here's where he's at. It's usually my strength coach loves to do this stuff. I'm more of just actually trying stuff out in the athletic training room, but I get a lot of feedback from him as far as here's what he's looking at. And he's been pretty spot on about guys, determining whether they're ready or not, or just their bodies in general are ready. So yeah, we do use this stuff. I'm trying to think of what the name of it was. I've got videos of it. I can send it out of what he's doing. It's a single force plate, we test the whole body, from vertical jumps all the way down to single arm push up stuff, just holding it there.
Interesting. Is there anybody else that would be willing to share some of their force plate stuff if they do use it?
Yeah, Jason, I'm chiming in here from Notre Dame, Scott Stansberry. Just we had a continuing ed seminar earlier in the fall, and one of the presenters actually had brought this up as the force plate stuff with the shoulder, the ASH test, and we actually used it. I actually used it on a position guy who had a non-dominant shoulder dislocation last summer, and we used it because he was our leadoff hitter. He's our base, he's our base stealer. He's our guy, and there's really no way to test, whether they're ready to dive back into a base and things like that. So we actually use this quite a bit in December and January, just to see where his progress was from a strength standpoint with his non-dominant, the arm that he dove back with. And like Adrian was saying, unless you really apply it, in that situation, it's really not useful. But our strength coach and I worked together on putting together the numbers and kind of presenting it to the coaching staff, and it was super helpful.
Pretty easy to follow along and create decisions based off of that information, Scott?
Yeah, like I said, we've only really used it on the one guy because it was presented to us and it was kind of a new thing. And we thought, well, let's try it and see what kind of information we can get. but fairly easy to kind of piece things together and put numbers. Obviously, you got to get through all the detail that the force plate gives you to get the numbers that you want, like the actual, like what you're looking for, whether you're looking for the peak torque or the peak force and those sorts of things. So that was a little bit time consuming because it was kind of our first time going through it. But I think in the future, I think using it, we'll have a better idea of what we're doing. We've also used, we used previously the Biodex for upper extremity testing, but that seemed to be a little bit more difficult, just with the modified neutral position and those sorts of things. So we actually went to a handheld dynamometer for shoulder strength, internal, external rotation, using the percentages and the norms. And that actually seems to give us some good numbers too from a return to play, like specifically for an elbow or a shoulder throwing arm type of stuff. But I will say with the ASH test, I think the problem right now, or at least it was in the fall, was what our presenter said was that there aren't really a whole lot of norms for this yet. And I think it's just because it hasn't really been studied. It's a relatively new test that's out there. So there aren't a lot of norms that you can kind of base off of, like so-and-so, this should be this norm or whatever. So I think that's why you have to do kind of both sides, right, left, and compare bilaterally and see what they're, what you're going for, if it's dominant arm versus non-dominant arm and those kind of things of what you're looking for.
Yeah, I think that's pretty similar to some of the other tech that's out there as well. I mean, like Modus is a great tool, and I've used it a handful of times only on injured athletes, obviously, because I've never been in a place that I can afford to get them for every pitcher. But I think they have a value for testing consistency and making sure that you're following things. I mean, I had some on guys that were doing rehabs where it didn't record every throw. Or, I really don't, and this is just me anecdotally, but I really don't think that the stress that's given in there as far as torque Newton meters on the elbow is accurate to just the elbow. And if it was, in my opinion, every time I've ever had a guy throw under a 5-ounce ball, they probably would have popped. But again, that's just my opinion and what I've seen just by using it. And I also used, one of the first or second generation models that they had, and obviously they've progressed since then. So there's probably some differences in my experience versus others. Sean, do you want to touch a little bit on what you guys do with Sparta Science real quick?
Sure. Scott, I really appreciate your explanation of the ASH test. That's a brilliant usage of the technology, and I think you use the technology to confirm what you needed to know as far as your position player. It's awesome. That's what we should be doing. At the University of Georgia, we're in year 3 working with Sparta Science. Again, it's a force plate. We do vertical jump testing almost every time we lift weights. And what we're looking at is just longitudinally their force plate numbers. And it's allowed us to go to coach and say, hey, this group of position players demonstrates that they're fatigued. And our coach has been wonderful about actually changing the practices and making it easier for that group of players. The very interesting thing that we've seen is with our starting pitchers, we'll look at over a season, you can really kind of predict just based off their Sparta jump numbers how their outing was, how their fatigue level was out of that outing. And so that's helped the strength coach specifically to customize their lift that week. If a guy throws 100 pitches and he's exhausted in his legs, then we're going to modify that workout to be a little easier that week. And the flip side of that is if he gets shelled and is out in 2 innings and he's fresh, then we can ramp that up a little bit and kind of keep his overall threshold about where we need it for the season. So we've used it. It's been interesting. I don't know that I can explain to you. In fact, I know I can't explain to you how does a vertical jump test correlate directly to a rotational sport. But it's been good for us. It's very expensive. I think around 15 grand a year. So we're blessed to have it and be able to use it. So that's sort of my 2 cents on them.
One of the other concepts to kind of chit chat and discuss about is the fact that, regardless of what we're doing, we need to be thinking about comparing metrics from pre-injury to post-injury if you can. And if you're not, then why not? Whether that be strength and conditioning metrics or whether that be our screening metrics. And that's, one of the things that I think is still of value, even if you don't believe that a screening process is there to prevent injury or create mobility or increase performance or what have you, Dr. Christopher Camp, one of the docs that did a part of the presentation for the MLB webinar the other week, was talking about how they utilize pre and post screening for injuries and try and compare to that individual's norms versus just comparing to the norms that you're looking at on research. And I think that has a lot of validity. And you even look at, some of the rehab protocols for professional ranks and docs that are doing things to just those professional leagues. And, the Braves, just because I've had a kid go through one of their docs for a UCL, literally have FMS and PRI concepts built into their UCL return protocol. And I think that stuff like that is awesome. But I'd definitely be interested to opening the floor and hearing what some individuals have set in place in regards to a testing battery and some of the things that may be on this slide. All right, good talk. I'll see you out there. No. So, obviously I use a handful of these things. I know, easiest one in the world is range of motion comparison, and we all do that on a regular basis. I think there's a lot more literature for the lower extremity wide balance in regards to upper extremity injury than there is for the upper extremity, which just seems, counterintuitive, but there's a lot of evidence for a trunk lean during that test and extra stress on the arm and therefore creating injuries due to kinetic chain. KJOC score, if you're not familiar with, I definitely think is something you should be, and it's cumbersome, but I think learning about the history of where these types of questionnaires come from is huge. There's a newer version that was created in, I want to say 2010, called the DASH score, which is pretty similar. And these are just subjective questionnaires to kind of figure out where that individual is mentally, and that's a huge piece of that return to play puzzle, in my opinion. We already talked about the jump testing based on research and the correlation there. Obviously, there's, our progressive testing in regards to actual physical measurements of a one-arm seated shot put throw or push-up test. Endurance tests as far as the 90-90 drop, 90-90 wall taps or wall dribble, and then, the old time true and tested CKC upper extremity test. All these things are really good. Is there anything that maybe anybody's using that is not on this list as a return to play criteria? All right, we're all square pegs following into round holes. Good talk.
Hey, Jason.
Yep.
Sorry. Paul Walkoff at Georgia Tech. I'm going to throw out there, and just probably because I'm one of the older people on this call, but I still go back to a lot of subjective measurements. How do they feel? What are they telling me? What is their body telling me? And because we can look at every objective score we want, but if they don't feel well, then they shouldn't be out there. And on the opposite end, if they do feel great, but then we get some number that says, oh, well, you shouldn't be feeling great. Who do you believe? And what do you do there? And so that's just a little bit the way I approach it. We don't have any straight objective measurement. It's just a kind of a combination of a lot of little things, I think, that we use to determine if they're ready to play or not.
Yeah, I don't disagree with that, Paul, and I appreciate you chiming in. Do you have something that you use specifically that you've created, or are you more along the DASH and KJOC score lines?
No, it's nothing specific. Just, that we haven't created anything. It's just that we talk. We'll throw some of these out there. It depends on also who the doctor was that did a procedure. If they want an objective number or something like that. But mostly, we ask them how are they doing, and we watch how they're doing. And if you watch them, a lot of times you'll know if they're ready or not anyway.
Hey, Jason.
Go ahead, fire away.
This is Stan Conti. I just wanted to, first of all, I thought the presentation was excellent. And when specific to the answer just given, the KJAC score for me is really one of the best things, especially after a layoff. I have a whole 2 years of collegiate experience, but that Christmas break from Thanksgiving to January, when these guys are a lot on their own, a KJOC score really will tell you if you guys coming in with a problem. And doing serial KJOC scores throughout the season, beginning of the season, middle of the season, end of the season, and during layoffs helps you identify someone who might be coming in with a problem. It's not, although it hasn't been actually validated for the internet and doing it over other than paper and pencil. I utilized it very easy with the Survey Monkey program, and you're able to send that out to the player, and he's able to give it back to you in an hour. And it gives you this idea that, especially specific to that person, if they were at a 94 KJOC score and all of a sudden they come back at 82 after the Christmas break, that may be somebody you want to grab right away coming into the training room when they return.
Stan, is that something that you utilized while you were at Santa Clara?
Yeah, I did. And I thought it was really great for me because I didn't know the players very well when I walked in. Didn't know what their histories were so much, and didn't know what kind of players they were and people they were. Obviously, people sometimes on a survey have a tendency to under or over react to some of the numbers, and you can then get them very specific to them. The Survey Monkey thing is really great because you can do a lot of analytics out of that. To be able to look at pretty much everybody on a spreadsheet. It's quick and easy. Again, it's not validated for that. It's validated for paper and pencil, but I find that real cumbersome, and especially when people are out of town. I had problems right away when people would come back from break and then throw a bullpen the first day back in January, have a little pain, and then they tell me, oh, yeah, it was bothering me a little bit before Christmas. Would have been nice to know that before the bullpen.
Right. Well, thanks, Dan. I appreciate your input. That's awesome. If nobody else has anything to add towards the return to testing battery, I do have one more fun topic that is probably going to open up a relative can of worms, or at least I hope so. All right. So I want to preface this by saying something Sean and I talked about in regards to these discussions or roundtables is the fact that we don't have a whole lot of people giving input. And something that I will say to that is, there is a such thing as a dumb question. I won't say that there isn't a dumb question, but I do think that everybody's ideas are secluded to their own place, and therefore they're probably right based on their circumstances. So don't feel apprehensive to talking about some of these things or giving some input, because in reality, we all don't know until we know better that we're doing something that we shouldn't be, or anything of that nature. So this I thought was really interesting, and this popped up over social media, I want to say about a week ago. So Dr. Josh Heenan, and not criticizing him at all, but I still don't know what he's a doctor of, but he does put out a lot of very interesting baseball content. And he threw this one out the other day in regards to a commonality that he sees anecdotally with a lot of people that he's working with two reconstructions for UCL, which is pretty specific, in regards to a trail leg early hip flexion prior to ball release. So obviously kind of threw up some pictures here, and this is a still frame of that particular video. I did not bring the video on because this is more of just a topic of discussion, but this is snapped literally right before that ball leaves his hand, and this hip flexion, no joke, starts at foot plant. So it's interesting to see, because I've never truly seen an athlete that has one that bad, or has that exhibits that much hip flexion at foot plant or before ball release. And obviously, I put all this in here because I think that he's absolutely ridiculous. He's one of those guys that defies a movement screen, in my opinion, because he is such an elite athlete that he compensates in whatever way he needs to. If you follow him on Instagram and watch him do his lifting stuff or his throwing stuff at wherever he's at while he's in this quarantine, you can just tell that certain parts of his body really just don't move. I mean, he sits in lumbar extension almost the entire time he's playing catch with no flexion anywhere. So I thought that this was a really interesting part or topic of debate about potential anecdotal findings for, UCL injuries or what have you. And I think it's similar to, the inverted W. Is this just another one of those? And obviously there's different thoughts on whether the inverted W is good or bad based on how long you've been looking into it, but be interested to hear anybody's thoughts on this.
So Jason, I know exactly who you're talking about with this guy. I follow him, or I don't follow him, but he pops up a lot on my stuff on Instagram as well. He's got this whole he markets this thing that he's created a 90 mile per hour formula that he puts out there that he says he puts everybody through it and they've gotten up to at least 90 miles an hour. but I think and I may be off on when I'm saying this, but what you're going off of here, the inverted W, I think it's a lack of trunk stability that is a precursor to having like you saw this kid down here at the bottom that's just essentially folded in half. I think a lot of it has to do with just that trunk itself. No core stability whatsoever. I mean, he can be strong as he wants to as an ox, but if that core isn't stable like a bottle, I think that's what happens. But those are just my 2 cents worth of it from him and what I've seen off this guy and what he posts on Instagram.
Thanks, Adrian.
Stan Copy again. The interesting part about some of these things that are online is they're all anecdotal. There's really no studies behind them. So, Mike Rhino talks about this all the time. Don't believe anything you read on Instagram or Twitter. But I think the key, especially in the inverted W, that was the Strasburg issue and everything else, and that's why it got hurt so much, has to do with the timing of the delivery. And the fact is that the ball has to be up when your foot's hitting the ground. So if you have an inverted W, one of the problems is when you look at the inverted W as they're doing through the mechanics, their hand is way down at the bottom and has to rotate all the way back up. It's got a lot of distance to go before that foot gets down. And if that foot gets down, the front foot gets down, and the ball is not up, your front side goes. Okay, and when your front side goes, your elbow drags, it puts shear force on the shoulder. So this gets back to basic mechanics. People can package it any way they want, but what you need is standard good mechanics with good timing, which is hard to do. And most importantly, like when you have a Chapman or somebody like that who is an outlier, you throw those guys out, but they have to have reproducible mechanics. And that's probably the hardest part. What I saw in high school and college is they just can't reproduce their delivery. And when they do, they end up putting abnormal stresses in different areas that they're not used to. So the timing in regards to the mechanics is really key to this whole thing. This guy has more lumbar extension. That's okay for him because he's actually had the test of time, but he's an outlier. You need to keep looking at the middle of the bell-shaped curve for your players and not worry about the guys who are way on one side or the other. But the key is the timing of the delivery and reproducibility from my standpoint.
Well said, Stan. Yeah, I don't disagree. I mean, I've had one or two athletes here and there at several institutions that I've been at that just kind of defy the movement screens that I take them through. And, they do things, but it doesn't necessarily change a whole lot from a prep work or a mobility perspective. And they still move pretty damn well in regards to playing their sport because they've done it for so long and they just know how to do it without, creating a risk, I guess is the best way to put it. And they're still subject to injury like anybody else, just seem to be better at troubleshooting things than others. Anybody else have any thoughts on these wonderful anecdotal findings? All right. So something to add here towards the end. Obviously, thanks you guys for coming out again. This is awesome that we can keep doing this. But something that Dr. Dugas is really interested in is just information, right? Like he needs to know input about things that we are seeing on the front lines because obviously he doesn't necessarily get to interact with all of these or all these patients that are having this done. I can't imagine that he's done all 4,000s of the ones that Arthrex claims has been done up to this point. So below there is his information in regards to email if you guys want to send him stuff. And obviously we'll open up for a little more discussion on if anybody has dealt with these and some of their experiences that maybe we can touch on today.
So here at the University of Georgia, I have one of these on my current roster, and it was a complicated case. Even for me that has a little bit of experience with these. The player on my current roster is a two-way player, plays first base, outfield, and is a left-handed pitcher. And for the last 3 years, honestly, we've been kind of chasing our tails to try to figure out how to get this kid to be able to do everything he wants to do on the baseball field. Every time we touch the mound, there has to be some type of biomechanical flaw that this kid has because to the best of my knowledge and to the best of the understanding of Dr. Dugas and Dr. Kane in Birmingham, they don't believe it's necessarily the surgery that's causing his issue. That's all checked out very thoroughly. We think it's some type of flexor stress that every time he throws any extended bullpen sessions, he gets a lot of flexor tendon pain. So that's one that we've brought to Dr. Dugas and Dr. Kane. That wasn't a clear cut, rainbows and sunshine case. The player's able to hit. He's able to play first base. He's able to play outfield, but it's the pitching mound that's been his nemesis. So that's just one that I've had, and I'd love to hear from anybody else. And the same thing, Dr. Dugas would love to hear from you guys if you've had interesting cases or really any feedback you've got. He'd love to hear from you.
Sean, Stan Conti again. Listen, I think what you really touched on right there is the two-way player. And we're seeing more and more two-way players. I think there needs to be some studies, especially at the collegiate level, because you see much more of that than at the professional level. But even though it's creeping up into the professional level, I really think people need to start collecting data on these two-way players to see exactly where they do and where are the problems that occur over a bigger sample size than one or two. It's going to keep going with the pro guys trying to go two ways. We're going to see more and more of the high school and college guys do it. And I think the population that you guys see and treat is more conducive to getting a larger sample size. And you ought to think about possibly getting a study group together and just look at two-way players and look at them from a statistical standpoint and any other analytics that you can pull together to see if something comes out that says that they can do this or that the majority of them fail, and where do they fail if they do fail. I think it's a very interesting study that you should be thinking about.
It's a really good point, Stan. And obviously, like one of my first thoughts is, what about catchers? And obviously, a lower population in regards to having to have this procedure done. But is it as successful in catchers versus other positions? And catchers take a beating, and their throwing mechanics are different from going down to one knee. It doesn't have to necessarily be as aggressive at times, but super aggressive at others. So there's a lot of different considerations there for sure.
Yeah, catchers are my favorite because they get beat up so much, and they also show the highest highest rate of injuries per capita, if you will. Only one catcher on the field, typically only two or three in the on the roster. They seem to get hurt more often. And from a reconstruction standpoint, study that we did with Christopher Camp, we looked at position players and the return of play of a position player was about 77 to 80%. Catchers were at 50% return. Small sample size, but we see this in everything else. All the other injuries that we look at from an epidemiological standpoint, we see catchers just get the crap knocked out of them, and they have a hard time coming back because that's a really, really tough position. So they're kind of on my radar from a study standpoint.
So I will leave this up here for a little bit if anybody wants to take a look. And like I said, we'll be sending these out later. But I'm going to